Hello everybody and welcome to our module on porphyrias. Porphyrins are large nitrogen-containing molecules that are important components of heme, which as you may know is an important component of hemoglobin. At the bottom left side of the screen is the structure of protoporphyrin. Protoporphyrin is part of the heme molecule. When you add an iron to the middle of a protoporphyrin molecule, you get a molecule of heme. So porphyrias are disorders of porphyrin synthesis, and they all result from deficient enzymes in the heme synthesis pathway. What's interesting about these disorders is that they rarely cause anemia. You would think if there were problems synthesizing heme that this would lead to decreased production of hemoglobin and therefore an anemia. However, usually the enzymes function to enough of a degree that you can make heme for hemoglobin. The problem is that intermediates begin to accumulate, and the accumulation of these porphyrin intermediates is what leads to the symptoms of these disorders. So let's review some details about heme. This is its structure at the bottom right side of the screen here. It's an important component of hemoglobin, and it's mostly produced in the bone marrow and the liver. Now, most people know that heme is made in the bone marrow where red blood cells are produced, and this is where 80% of heme production occurs, and the heme that's produced in the bone marrow goes into the red cells as hemoglobin. However, you also want to remember that the liver produces a significant quantity of heme. About 20% of heme production occurs in the liver, and it's used in the cytochrome P450 enzymes, and this will be important later when we talk about things that can exacerbate the porphyria conditions. Anything that increases the activity of these cytochrome P450 enzymes can increase the symptoms of some of the porphyrias, and that's because heme is produced in the liver as part of these enzymes. Heme synthesis begins in the mitochondria. The initial ingredients are succinyl-CoA, which you may know is an intermediate in the TCA cycle, and also the amino acid glycine. They are combined to form a molecule called delta-aminolevulonic acid, or D-ALA, and the enzyme that does this is D-ALA synthase. And this is the rate-limiting step in heme synthesis. This enzyme's activity is inhibited by heme, so that when there are sufficient quantities of heme, this enzyme is less active, and when there's not enough heme, this enzyme is more active. The middle pathway of heme synthesis occurs in the cytosol, and then the final steps also occur back in the mitochondria. We'll see how all of this occurs in a few slides. This is a slide showing heme synthesis that I used in the module on microcytic anemias, and in that module I talked about how sideroblastic anemias and lead poisoning could inhibit several enzymes in the heme synthesis pathway to such a degree that heme production was impaired and anemia resulted. So just by way of review, I want to point out that in the sideroblastic anemias, D-ALA synthase is ineffective, and that leads to decreased heme synthesis and a microcytic anemia. In lead poisoning, the enzyme D-ALA dehydratase and ferrochelatase can be inhibited, and that also can lead to decreased heme production and an anemia. Here's another map of the heme synthesis pathway. This is the map that we'll use to understand the porphyrias. The process begins in the mitochondria, where succinyl-CoA and glycine are combined by D-ALA synthase to form D-ALA. The process then moves out into the cytosol, where there are a series of steps. It then returns back to the mitochondria for the final steps, where protoporphyrin is combined with iron to form heme. Heme then exerts negative feedback on D-ALA synthase. The porphyrias are a group of disorders. More than 8 of them have been described. The 2 most common, keeping in mind they're all very rare, are porphyria cutanea tarda and acute intermittent porphyria. Both of these disorders, which we'll talk about in this module today, do not cause anemia. There's no significant drop in the hemoglobin concentration. They're sometimes referred to as hepatic porphyrias because they primarily affect heme synthesis in the liver, and the symptoms from these disorders all come from accumulation of intermediates, not from a drop in the hemoglobin level. Porphyria cutanea tarda, it's often called PCT, is the most common porphyria. It results from deficiency of the enzyme UROD, which is uroporphyrinogen decarboxylase. This is the 5th enzyme in the heme synthesis pathway. Going back to our map of the heme synthesis pathway, this is where the enzyme UROD exerts its effects. It converts a structure called uroporphyrinogen 3 into another structure called coprophyrinogen 3, and this is the 5th enzyme in the heme synthesis pathway. To understand this disorder, we need to work through a little bit of chemical vocabulary. So let's take a look at the chemical structure of uroporphyrinogen 3 at the bottom right side of the screen. You can see that the center of the structure is 4 rings, much like what you will ultimately find in heme molecules. Dangling off those 4 rings are a number of groups that end in a carboxylic acid. Some of those groups have 3 carbons. For example, this one right here has 3 carbons. I'm circling them now. Others of these groups dangling off the central molecule have only 2 carbons. For example, this one has only 2 carbons right here. So a uroporphyrinogen is a molecule that has 4 propionic acid groups. Those are the groups with 3 carbons. And also 4 acetic acid groups. Those are the groups with 2 carbons. And it's named uroporphyrinogen 1 or uroporphyrinogen 3 depending on the different arrangements of the propionic acid groups and the acetic acid groups. Uroporphyrinogen 3 is the more common form. That's the form I showed on the last slide in the heme synthesis pathway, and forms 2 and 4 do not even occur naturally. To make this more clear, I've shown the structure of uroporphyrinogen 3 on the left side of the screen and uroporphyrinogen 1 on the right side of the screen. I'll now overlay them with the letters A or P, A for the acetic acid groups and P for the propionic acid groups. And you can see that in uroporphyrinogen 1 it always alternates AP, AP. On the other hand, in uroporphyrinogen 3 there's a section here where it does not alternate, it goes PAAP, and that's the different structure of the carboxylic acid groups that gives uroporphyrinogen 3 its name versus uroporphyrinogen 1. Just a little more vocabulary and then we'll return to our discussion of the porphyrias. A porphyrinogen is a non-oxidized molecule. A porphyrin is an oxidized molecule, meaning that it has lost hydrogen. If you look at the bottom left side of the screen, again I've shown the structure of uroporphyrinogen 3. To convert that to uroporphyrin 3, it must be oxidized. This means it must lose hydrogen. And you can see that there are a series of single bonds here between the rings inside of the molecule. They have now been converted into double bonds in the structure of uroporphyrin 3. That means that oxidation has taken place, and that is the difference between uroporphyrinogen and uroporphyrin. So back to Porphyria cutanea tarda. In this disorder, there is accumulation of uroporphyrinogen. At the bottom of the screen, I've shown the reaction that urod catalyzes. It converts uroporphyrinogen 3 into the structure coproporphyrinogen 3. And when urod is deficient, that leads to the disorder Porphyria cutanea tarda. The uroporphyrinogen that accumulates will be oxidized and become uroporphyrin. This will appear in the plasma and be excreted in the urine. It's also transported to the skin, and in the skin it causes skin damage on exposure to light, which is a major feature of this disorder. That's why the word cutanea is in the name. Once you understand that, it's very easy to understand the symptoms of Porphyria cutanea tarda. These patients have chronic blistering skin lesions from the accumulation of uroporphyrins in the skin. This is often accompanied by evidence of hepatitis, including an increased AST and ALT. This is because heme synthesis is impaired in the liver and uroporphyrins are accumulating in the liver and causing liver damage. In addition, the urine appears tea-colored. That's because uroporphyrins are being filtered in the glomeruli and going out in the urine and changing the color of the urine. A few more details on the pathophysiology of Porphyria cutanea tarda. Decreased urod activity is usually acquired. The type 1 version of this disorder has normal gene function. An unknown environmental trigger leads to decreased urod activity. Another thing to be aware of is that excess iron plays a central role in this disorder. If you do a liver biopsy on patients with this disorder, you often find increased hepatic iron. And in fact, phlebotomy is sometimes used for treatment because it reduces iron stores. PCT is considered an example of an iron overload syndrome similar to hemochromatosis. If you remember that heme is synthesized in the liver to be used in cytochrome P450 enzymes, then it's easy to remember some of the susceptibility factors for Porphyria cutanea tarda. These are all factors that can worsen the disease, and many of them are also things that you probably know affect the liver. So alcohol consumption can affect the liver, and it can also worsen Porphyria cutanea tarda. Hepatitis C affects the liver, obviously. And then finally, HIV is also a well-described susceptibility factor for this disorder. The diagnosis of this disorder is complex. It's often done at specialized centers, but some of the principles are easy to understand if you know the biochemistry we talked about. You can first of all measure the plasma or urine porphyrin levels for screening. They will be elevated in this disorder as well as many other porphyrias. Once you determine that the porphyrin levels are high, you can then fractionate them, and you will find that the uroporphyrin level is increased because of the deficiency of urod. As I said before, this disorder is often treated with phlebotomy because if you remove the excess iron, the liver function can improve. In addition, hydroxychloroquine, a malaria drug, is often used. The mechanism of this drug's benefit is unclear. This was actually discovered incidentally years ago when patients were given this drug for reasons other than porphyria, and they noticed that the porphyria symptoms could improve under certain circumstances. Far and away, the coolest feature of this very rare disorder is that there is a hypothesis that it is the origin of the vampire myth. Patients with this condition often avoid the sun because it can exacerbate the skin symptoms. The hypothesis also states that they may have drank blood because by consuming heme, they inhibit heme synthesis in the liver, and that could improve their symptoms. This is probably not true, it's just a hypothesis, but I've always found it the most interesting feature of this very rare disorder. The second porphyria we'll discuss is called acute intermittent porphyria. This is a deficiency of the enzyme PBGD, which stands for porphyrobilinogen deaminase. It is the third enzyme in the heme synthesis pathway. This is an autosomal dominant disorder, so it tends to run in families. It has a low penetrance, however, so the symptoms are variable from one family member to the next. Going back to our map of the heme synthesis pathway, this is where porphyrobilinogen deaminase functions. It converts porphyrobilinogen into a molecule called hydroxymethylbilane. And a general rule of thumb is that enzyme deficiencies late in the heme synthesis pathway tend to cause skin symptoms. Enzyme deficiencies early in the pathway, like porphyrobilinogen deaminase, tend to cause neurological symptoms, as we will see when we talk more about acute intermittent porphyria. This disorder gets its name because the symptoms occur as acute intermittent attacks. They only occur when levels of porphyrobilinogen rise. Remember that PBGD converts porphyrobilinogen into hydroxymethylbilane. Porphyrobilinogen levels will rise anytime the rate-limiting enzyme in the heme synthesis pathway is activated. Remember that that enzyme is D-allosynthetase. It has feedback inhibition by heme, so anything that activates D-allosynthetase will ramp up the activity of heme synthesis in the liver, and that will lead to a rise in porphyrobilinogen levels, and that will lead to an acute attack. So what could ramp up heme synthesis in the liver? Well, remember that heme in the liver is used for the cytochrome P450 system. So any medication that induces the P450 system can increase heme synthesis in the liver. This will lead to a rise in porphyrobilinogen levels, and this will be a trigger for the symptoms of acute intermittent porphyria. So patients with this very rare condition have to avoid a long list of medications that can induce the P450 system. Some of the classic drugs to do this include griseofulvin, which is an antifungal, and also phenobarbital, which is a seizure medication. If patients with AIP take either of these drugs, they will get very sick. Other triggers for the condition include alcohol and smoking, and then also starvation or reduced intake of calories is also a classic trigger. Low glucose activates allosynthetase, and this leads to more production of heme and a rise in the porphyrobilinogen levels. The reason the symptoms in acute intermittent porphyria occur are because D-allo and porphyrobilinogen are neurotoxins. If we go back to this slide, when this enzyme is dysfunctional, the levels of porphyrobilinogen will rise. The levels of D-allo can also rise, especially when D-allosynthetase is activated by one of those triggers. So when those neurotoxin levels elevate, patients can develop cerebral dysfunction, especially confusion and delirium and dementia. They can develop neuropathy, and they can develop abdominal pain, and all of these are classic features of acute intermittent porphyria. So the symptoms are often remembered by the 5 Ps. The first P is abdominal pain. The second P is port wine colored urine. Porphyrins change the color of the urine. Polyneuropathy is the third P, then psychological disturbances, and finally precipitated by drugs. In actual life, these symptoms are so diffuse and nonspecific that this disorder often goes undiagnosed for a long period of time until some astute clinician makes the diagnosis. So the classic case is an adult in their 30s or 40s. For reasons that are poorly understood, this disorder usually does not present in childhood. The patient will have recurrent unexplained abdominal pain attacks, there will be an abnormal color of the urine, and there will also be confusion and/or neuropathy. There's a lot of interest among historians about this disorder regarding King George III. You may know that he was the king during the American Revolution and the American War of Independence. Later in life, his urine began to change color, and he developed dementia and ultimately died. It's thought that he may have had acute intermittent porphyria or some variant of it. There's also a thought that other members of the royal family in that period of history may also have had porphyrias. The diagnosis of acute intermittent porphyria is complex. You can read about all the different enzyme tests that are used. Some principles that you should know for step 1 are that it's best to test during an attack. That's when the porphyrin levels will be high. In addition, you should definitely know the 2 intermediates in the heme synthesis pathway whose levels can accumulate in this disorder. Those are high levels of porphyrobilinogen or PBG and high levels of D-allo. The treatment of this disorder is complex. First of all, patients need to avoid all those triggers we talked about a few slides ago, but some other therapies are sometimes used, and the principle behind these treatments is that they inhibit heme production, and therefore they blunt the production from the liver of those toxic intermediates in the heme synthesis pathway. 2 therapies that are sometimes used are hemin, which is a synthetic heme, and glucose. Both of these inhibit the activity of the hepatic D-allosynthetase enzyme, and remember, this is the rate-limiting enzyme for the synthetic pathway of heme in the liver. And that concludes our module on porphyrias.